Good morning, everybody. The warriors, the winners, the night hawkers, and the NEET PG dreamers. Most welcome to this wonderful early morning. Paritosh Jha. Hey, there's a link on the top. Can you please check? ahaslides.com, ahaslides.com/192D7, 192D7, 192D7, yeah. Very good. If you go to this link, quiz link, general medicine is an interesting subject, whether it is early morning, midnight, afternoon, or during the REM or NREM sleep also. I just wanted to check how energetic, enthusiastic, and ready to fight you all guys if I do a session at early morning 1 a.m. Right? 001 says, "Sir, I am remembering the old days when you were live at 4 a.m. Yes. Of course, guys, to spend a great time along with all of you. There is no more enjoyable thing than that. And thank you all for joining the session. Chalo bhaiya, shuru karenge. Who is going to become the winner of this general medicine quiz on this midnight Masala medicine show with Murali Bharadwaz Sir? Right? So let us check. So, doctor, without much of waiting, I'm starting the quiz. And of course, you can inform all your friends that we fought early morning and we fought on the sea, we fought on the roads, we fought on the land, we fought on the mountains, we fought in the air, but ultimately we won the world war. So, doctor, let's make the great beginning. Shuru kare? That's right. Oh, 1 minute. Yes. Right. So let me start the quiz. There are 23 questions in general medicine, doctor. Which of the following about heparin-induced thrombocytopenia is false? Punch your answers, doctor. is the most specific diagnostic test is, oh, sorry, doctor, the correct option was missing. Yeah, neither the first and second both are true. Venous thrombosis is more common than arterial thrombosis, and most specific diagnostic test is serotonin release assay is what you need to remember. So whenever you're administering heparin, good to see Abhijit on the top, Muhammad Sadiq, Harrison Al Kaminaini, Min, and many more. Very good. So early recognition, prompt discontinuation of heparin, and using the alternative anticoagulants other than heparin is the main treatment. Argatroban, lepiridine, danaperoid, bilabudin, and fondaparinux, they're all very effective in the heparin-induced thrombocytopenia is what you need to remember. That's good. Question number 2. Which is not a functional platelet disorder of adhesion? You know, platelet disorders are divided into disorders of aggregation, disorders of adhesion. Now tell me, which is not a functional platelet disorder of adhesion? Yup. So von Willebrand, Bernard-Solia, uremia, these are all the disorders of adhesion. Glanzmann is more to do with aggregation. That's the point you need to appreciate. Whoa! Al-Khamenei and Harrison, they both are competing together. In spite of 1 a.m. in the morning, I'm proud to see 17 online students. Great, doctor. So the disorders of adhesion are Bernard-Solia, von Willebrand. They can be acquired also, like uremia and acquired von Willebrand. Very good, doctor. So the next question number 3. Which is a functional platelet disorder of aggregation? This, all of you will answer it correctly, I know that. Good to see 18 online students at 1 a.m. Whatever, kya maza hai. Excellent. Glanzmann's thrombasthenia. So Glanzmann is aggregation, von Willebrand, Bernard-Solia is adhesion. You should not forget, right? Now, that keeps Al-Khamenei, Harrison, Abhijit, Basha, 001, everyone is right. Good. So efibrinogenemia, Glanzmann's thrombasthenia. They are the inherited platelet disorders of aggregation. Whereas ticlopidine, GP2B3A inhibitors, dysproteinemias, they are the acquired platelet disorders of aggregation. That's the main difference you need to appreciate. Question number 4. Where do you see acquired von Willebrand disease most commonly? Whoever answers is nowadays reading Harrison. Nowadays tearing the pages of Harrison. Come on. Excellent. 5 of you are rocking, doctor. MGUS, monoclonal gammopathy of undetermined significance, is the most common cause of the acquired von Willebrand disease. Ditto, same question will come in tomorrow FMGE exam. What will you give me? You send me a Cadbury chocolate on the WhatsApp. Barabar? Very good. That makes Harrison on the top. Move. Now, doc, question number 5. Desmopressin is most effective for treatment of which type of von Willebrand? So there are subtypes of von Willebrand you should know. If you are getting completely washed out in clean bowl, doctor, please go back to the onlinemmbbs.com video library. And we had a wonderful discussion on von Willebrand, Bernard-Solier, glandular thrombosthenia, and everything. It is type 1. It is the type 1. That makes Harrison Superman, Spider-Man is the Harrison. Very good. So type 1 von Willebrand disease is best treated with desmopressin, because desmopressin causes the release of von Willebrand factor and factor VIII from the endothelial stores. Weber-Pelade bodies, you need to remember. Okay, now the next question. Question number 6. Desmopressin should not be given in which type of von Willebrand disease? Let us see who will answer this. Should not be given. It is not indicated. Absolutely. Type 2B, type 2B type of von Willebrand disease. 001 Al-Khamenei Basha. They're only correct. So, if you happen to give desmopressin in type 2B, it is going to worsen the thrombocytopenia. You need to remember. Right? Now, question number 7. Which is the clotting factor with the shortest half-life? Come on. Let me see who is going to crack this question. So you all know 2, 5, 10 come under APTD, common pathway. 7 is PT. So 7 has shortest half-life. So that is the reason though 2, 7, 9, 10, all of them are vitamin K dependent. Whenever there is a vitamin K deficiency, first to fall is factor 7, which has the shortest half-life. That is the reason whenever early vitamin K deficiency is there, because the factor 7 falls first, only PT is prolonged. Later on, both PT and FTD are prolonged. Right? So you remember this. Very good to see 17 players. Preeti is awake. Auditi, Shiva, Mauni. Very good, very good, very good. Tomorrow morning when you wake up, you tell your friends, hey, we all played early morning 1 a.m. midnight masala medicine with Murali Bharadwaz Sir. Deal? Good. Question number 8. P2X1, P2Y1, P2Y12. These are all receptors. Which receptors? Subtypes of which receptors? Let us see. Whoa! They're all the subtypes of ADP receptors, is what you need to remember. So that makes Harrison to fly to the top. Now, so activation of P2Y12, P2Y1 receptors will lead to ADP-induced platelet aggregation. And if you look, clopidogrel, prasugrel, how do they work? They're all inhibitors of ADP-induced platelet aggregation, is what you have to remember. Now, question number 9. P7 P-selectin glycoprotein ligand 1, PSGL1, is associated with what? Platelet surface receptor or leukocyte receptor or endothelial receptor? Come on, come on, come on. Yes. So you need to be very sure on all these chota mota receptors. So actually the correct answer is oh sorry. The correct answer one minute, doctor. I think I'm sorry. I think I lost the continuity of the quiz. Sorry about that. 1 minute. Yeah, let's continue with the question number 11. I think the earlier question, it was a platelet receptors it is associated. Okay. Now, chronic cor pulmonale is more common in wood situation. Yes. Very good. 12 of you are right. Of all the conditions mentioned, severe kyphoscoliosis is most often associated with the chronic cor pulmonale. Excellent. That makes Harrison on the leading edge. Now, question number 12. In order to reduce the incidence of high altitude pulmonary edema, prophylactic inhalation of wood substance reduces the incidence of high altitude pulmonary edema. Yes, doc. Bravo. Basically, for the exercise-induced asthma, nocturnal asthma, and prophylactically to reduce the high altitude pulmonary edema, we use the beta-2 agonist salmeterol, which is a LABA. Long-acting beta-2 agonist is what you need to remember. Now, doctor, question number 13. Yes. Punch your answer. In anemic hypoxia, how will be the PaO2? How will be the PaO2? That's beautiful. It is typically normal because it is anemic hypoxia. This is very important. The different causes of hypoxia and how will be the PaO2 levels is one of the favorite questions of the examiner. So, the next question. Question number 14. About the dichromatic pulse. What is false? About the dichromatic pulse. What is false? Whoa. It has two palpable waves, one in systole, one in diastole. Yes. It usually indicates a very low stroke volume. Yes. And it is found in dilated cardiomyopathy, not in restrictive cardiomyopathy, is what you need to remember. So that makes 001, Avijit has correctly answered. Great. So the dichromatic pulse has two palpable waves, one in diastole, one in systole. It denotes a low stroke volume like dilated cardiomyopathy is what you need to remember. Question number 15. intensity of the first heart sound is influenced by all these things except, yes, Panchuran said doc. Great. It is the position of the mitral leaflets at onset of the ventricular systole. Yes, that is a deciding factor. That's the reason the mitral stenosis will lead to a loud first heart sound. The rate of the rise of the left ventricular pressure pulse, yes, it is a deciding factor. And any structural disease of the mitral valve is also a deciding factor. Oh, Harrison lost it. Basha is in the second position. Min only correctly answered. Mauni, very few have correctly answered. Once more, Doctor, heart sounds is one of the high-yield topic of the examiner. So, any tachycardia, mitral stenosis, a short PR interval, any of them will lead to a loud first heart sound. That's what you need to remember. Question number 16. Morbids type 1 block. Morbids type 2 block. You need to be very clear. So, what is the wrong statement about Morbids type 2 block? Yes, doc. Give me a confident answer. Yes. Very good to see Yajnesh Yajat. Whoa. Yajnesh, if you want to join our daily rapid fire quizzes, I'm giving you the link. First, join our WhatsApp group. Every day morning, 11 a.m., 3 p.m., evening 7 p.m., 9 p.m., and midnight masala at 12 p.m. You are going to have 5 live quiz shows. And if you become the winner, you get 40,000 rupees worth of prize. So, doc, you know very well that a Morbids type 2 block has a great chance of going into complete heart block. And it can be because of a problem in the His-Purkinje system. Very good. A good number of you are absolutely right. Now, question number 17. Once more, about Morbids type 2 second degree AV block. So where does it occur? Where does it occur? So it usually occurs in the AV node. Is wrong. It occurs in anteroseptal myocardial infarction, yes. And any sclerodegenerative disorder or a calcification of the conduction system can lead to Morbids type 2 second degree heart block. And the block is usually in the His-Purkinje system, not in the AV node. It is below the level of the AV node. That's the point you need to appreciate. Question number 18. Once more, what is wrong about Morbids type 2 block? Morbids type 2 block. Yes. Excellent. So all these are the true statements. Typically, it occurs in the distal to the infra-His conduction system. There's an intermittent failure of the conduction of the P wave. right? So that's the point. Now, the next question. So intermittent failure of the conduction of the P wave without changes in the preceding PR or the RR intervals is the nature of the type 2 second degree AV block. It occurs distal or infra his conduction system and is often associated with bundle branch block, and it can lead to a complete heart block. You should know all these important points. Question number 19. So if you want to put a pacemaker in SCA nodal dysfunction, these are all the class 1 indications. You have to be very sure. Yes. ये तो थोड़ा DM लेवल वाला क्वेश्चन है, सुपर स्पेशलिटी लेवल का. So only Sam has done it correctly. So what are the class 4 indications for pacing in a SCA nodal dysfunction? If there is a bradycardia and patient is symptomatic, if the patient is on a long-term drug therapy with sinus node dysfunction, they are the important indications which you need to remember. Question number 20. After depolarizations are because of what? Because of the increase in what? Whoever answers is our future cardiologist. I can bet it if you answer this question correctly. Yup. 5 of you out of the 17 sitting over there, you are the future cardiologists. Intracellular calcium accumulation lead to after depolarizations. So 001, Paritosh, VLS, Shiva, and Rad. Get ready for a DM cardiology seat. So after depolarizations are attributable because of the increased intracellular calcium. Question number 21. Early after depolarizations, what will they lead to? Come on. So doctor, in onlineMBBS.com video library, you have a wonderful discussion of general medicine, cardiology, neurology, nephrology, hematology, gastroenterology. So subscribe to onlineMBBS.com video library, which is your boat or a ship to reach the destination called NEET PG. Early after depolarization will lead to the prolonged acuity, leading to a polymorphic ventricular tachycardia, leading to torsidis depointis is what you need to remember. Only Bhasha 24 have correctly answered. So whenever there are early depolarization, after depolarizations, they lead to ventricular premature complexes. They will trigger torsidis depointis. Whereas the late after depolarizations lead to atrial, junctional, fascicular tachyarrhythmias, which are typically seen in the case of the digoxin toxicity. Once more, that is exactly the next question. Late after depolarizations in digoxin toxicity, what do they lead to? Yes. Late after depolarizations, absolutely right. They lead to atrial tachyarrhythmias, junctional means AV node level. Fascicular tachyarrhythmias means bundle of His, but not for ventricular fibrillation. So Dr. Harrison Basha Avijit VLS. Correctly answered. So, the last question for this wonderful evening, the great guys who are awake early in the 1 a.m. in the morning, just I am doing this session to test how enthusiastic you guys are. In the atrial fibrillation, if the patient's clinical status is severely compromised, what is the treatment of choice? 10 of you correctly answered. Electrical cardioversion. Absolutely. Good to see. Harrison 001. Avijit. Absolutely rocking performance. Harrison Jindabad. Harrison, give a call to our helpline. Take a snapshot. Mohan Babu is becoming very malignantly preparing for the entrance. Very good, doctor. I'm proud of you. 9000868 So Mohan Babu can gift it to anybody, right? Congrats, Mohan Babu. And when you become NEET PG Topper tomorrow, don't forget that early morning 1 a.m. I was sitting with Dr. Murali Bharadwaz to do a midnight Masala medicine show, right? So, doctor, once more, enjoy a great sleep, a good food, a good sleep, and happiness. They are the essential ingredients of the human life. Let us not deprive ourselves of that. But still, aspiration, ambition, and to prove the purpose for which we are born. So what is the purpose of our birth? To serve the people, to top the NEET PG entrance, and justify our existence on this planet Earth. So thank you all for joining this wonderful evening, and never compromise. There is no failure than a low ambition. See you all tomorrow morning at 11 a.m. Good night.